This conference will now be recorded.
Hello everyone, I am Dr. Juma Bishwas. I am the mentor of RCOG Health. Today I will discuss one of the important topics that is best practice in abortion care, and I really appreciate RCOG for taking a holistic approach to abortion care in this best practice. Before starting of for the presentation, I will really appreciate if you subscribe my channel, press the bell button, and after the presentation, if you have any query, you can ask me on the comment box, and please share this to the other person so that everyone can get help from this abortion care. In every year, 25 million abortions are unsafe. That make it one of the leading cause of maternal mortality and the morbidity worldwide. Abortion-related death and mortality can largely preventable if we provide safe abortion care, if we timely do the post-abortion care, and by access to contraception and comprehensive sexual education. There are two methods of abortions we do. One is medical abortion, one is surgical abortion. Medical abortion, we use medications to end up the pregnancy, and most commonly we use misoprostol alone or in combination with mifepristone. In case of surgical abortion, we use manual vacuum aspiration, elective vacuum aspiration, and dilatation and evacuation. These are the comparison between the medical abortion and the surgical abortion. Medical abortions, in that case, it's a very safest options. In comparison with the surgical abortion, we can avoid surgery and it mimic the miscarriage, and anyone can take it in a place at home, and it will take hours to days to complete, but the time may not be predictable. Medication sometimes can cause some risk like nausea, vomiting, diarrhea, chills, and fever in 1% of the cases. Sometimes patient will experience abdominal cramping, bleeding while passing the pregnancy, and this cramp and bleeding can last for 2 to 3 weeks. Serious complication is very uncommon, and after the abortion they can take all the contraceptive method except intrauterine device, which can be inserted immediately after the pregnancy is expelled. In case of surgical abortion, it should be performed in the hospital, and patient will experience some discomfort during the procedures if it is conducted by sedation and or local anesthetic, but they will not experience any kind of discomfort if it is performed under general anesthesia. Sometimes we use some medication for preparation of the cervix that can cause cramp and bleeding. Sometimes it can cause nausea, vomiting, diarrhea, chills, and rigor. Patient will experience pain and bleeding 1 to 2 weeks after that. So it is much more in medical abortion. It will persist for 2 to 3 weeks, but in surgical abortion, it will persist only for 1 or 2 weeks. They required a pelvic examination and insertion of surgical instrument into the uterus. Serious complications are uncommon, and after the procedures, all the contraceptive method can be started immediately. If you see the complication and the risk of abortion, according to the NICE, you can see the continuing pregnancy in case of medical abortion a bit higher, like 1 to 2% of the cases. In case of surgical abortion, it is 1 in 1,000. Higher if the pregnancy is less than 7 weeks. Need for further intervention is much more in the medical abortion in comparison with the surgical. That is less than 14 weeks in case of medical abortion, that will be 70 in 1,000. More than 40 weeks, that will be 13%. In case of surgical abortion, less than 14 weeks, that will be 35 in 1,000. More than 40 weeks, that will be 3%. Risk of infection is bit same with the medical and the surgical, that is 1%. Severe bleeding requiring transfusions, that's also the same in both cases. Less than 20 weeks, that will be less than 1 in 1,000. More than 20 weeks, that will be 4 in 1,000. Cervical injury from dilatation and the manipulation, it's in the surgical abortion, it's 1% of the cases. Perforation is 1 to 4 in 1,000 of the cases. Uterine rupture, less than 1 in 1,000 for second trimester medical abortion, that can happen. So medical abortion, there are few contraindications, like if there's any known or suspected ectopic pregnancy, if anyone allergic to mifepristone or misoprostol, if any case of uncontrolled asthma, chronic adrenal failure, and inherited porphyria. So in the last three cases, mifepristone is actually contraindicated. In that cases, misoprostol alone could be considered. There are some extra consideration and additional care planning needs before starting of the medical abortion. Like if the patient is taking long-term steroid therapy, their dose needs to be adjusted by specialist advice, because mifepristone is a glucocorticoid receptor antagonist, and that inhibits the action of steroid therapy, and that can exacerbate the condition. So in that case, their steroid dose needs to be adjusted before going for medical abortion. Anticoagulant therapy that needs to be stopped before abortion medication are administered, then restarted after the abortion. If anyone have bleeding disorders, in that case, they need to take the medical management at in hospital rather than at home. Symptomatic anemia, their hemoglobin concentration should be optimized, and they may need additional care in hospital setting. If any patients have IUCD, in that case, that should be removed in advance of the treatment. If IUD cannot be retrieved, it is important to confirm that it is expelled during the procedures by using X-ray abdomen after the abortion. In case of surgical abortion, it is contraindicated if the pregnancy cannot be removed through the cervix, for example, due to obstructing tumor. There are certain medical conditions that can affect the choice of anesthesia and may require additional or specialist equipment. For an example, if the woman have any bleeding disorder or abnormal placentation, or if anyone taking anticoagulant medications or having severe cardiopulmonary disease, certain cases that can challenge the abortion, like high BMI, distortion of the uterine cavity by fibroid or another anomaly, previous cervical surgery, or type 3 female genital mutilation. So in that case, we can use other various way we can do that. Like we can change the patient positioning, we can use long instrument for evacuation. Sometimes we can perform under ultrasound guidance, and before proceeding we can do the cervical preparation. STI screening is best practice to do for everyone before undergoing any kind of abortion procedures, for especially for chlamydia and gonorrhea, and also all other bloodborne viruses like HIV and syphilis. But that shouldn't be delayed the procedures of the abortion, and administer the treatment dose of the antibiotic if anyone have any sign and symptom of STIs. For prevention of post-abortion infection, prophylactic antibiotic is not required for the medical abortion, but in surgical abortion, we can consider that to prevent any kind of infection. Optimum regimen is not known, but usually we start nitroimidazole, that is metronidazole, tetracycline, and penicillin. And this is the regimen we use for surgical or incomplete abortion, like oral doxycycline 100 milligram BD for 3 to 7 days. We should start it within 2 hours of the procedures. Blood test as a routine, we don't do that. But the determination of the rhesus blood status, that should be considered if the duration of the pregnancy is more than 12 weeks, and anti-D should be available there. Regarding contraception, all the contraceptive method can be started at the time of surgical abortion, but in case of medical abortion, we can use all the contraceptive except intrauterine contraceptive device. We can use it following expulsion of the pregnancy after a medical abortion. Additional contraceptive precautions are not required if the contraception is initiated immediately or within 5 days of an abortion. If anyone requested for the sterilization, this should ideally only be performed after some time has elapsed after the abortion, because that can increase the failure rate. Sometimes patients may think about reversal of the sterilization. So in that case, they need some time after abortion to make up their mind, and then they can go for sterilization. So you can see that post-abortion contraception in the first trimester, any of the contraceptive method you can prescribe. Second trimester, any of the contraceptive you can prescribe. But for medical eligibility criteria category, intrauterine copper device or Mirena is a category 2. For immediate post-septic abortion, Mirena and copper device should be avoided because it's medical eligibility criteria 4. So you can prescribe any of that, but except copper IUD and Mirena. So now let's talk about the way we do the medical abortion. So before 12 weeks of the pregnancy, mifepristone we should prescribe 200 mg orally, followed by 24 to 48 hours later, misoprostol 800 microgram, vaginal, buccal or sublingual route. If the expulsion is not occur within 4 hours, we can give additional dose of misoprostol, that is 400 microgram, vaginal, buccal or sublingual. If the mifepristone is not available, then we can use misoprostol 400 microgram, vaginal, buccal or sublingual route, followed by misoprostol 400 microgram every 3 hourly until the pregnancy has passed. In 12 to 24 weeks of the pregnancy, medical abortion should be performed in the hospital. So we can give mifepristone 200 mg orally, followed by 24 to 48 hours later misoprostol, that will be 800 microgram, vaginal, buccal or sublingual, followed by misoprostol 400 microgram every 3 hourly until abortion occurs. So after 12 weeks, you have to give misoprostol every 3 hourly. But before 12 weeks, you can give a stat dose of the misoprostol. If the mifepristone is not available, in that case, misoprostol 800 microgram, followed by misoprostol 400 microgram, you have to give every 3 hourly until abortion occurs. So 12 to 24 weeks onward, in that case, you have to give misoprostol every 3 hourly. But in case of 12 weeks or less than that, in that case, you can give only a stat dose of misoprostol after mifepristone. Surgical abortion before 14 weeks, that can be performed by using vacuum aspiration, that is electrical or manual vacuum aspiration. Surgical abortion between 14 to 24 weeks, that can be performed by dilatation and evacuation. But if anyone think about vacuum aspiration between 15 to 16 weeks, in that case, they need a large bore suction tubing with the cannulas up to 16 millimeter in diameter. Before surgical procedures, some cases they need a cervical preparation. Like before 12 weeks, they need mifepristone 200 mg orally. Then 24 to 48 hours before the procedures, you have to prescribe that. Or you can give misoprostol 400 mg sublingually 1 to 2 hours before the procedures, or misoprostol 400 microgram vaginal or buccal 2 to 3 hours before the procedures. 12 to 18 plus 6 weeks of the pregnancy, they need a combination of mifi and misoprostol, or you can use osmotic dilator plus either mifi or misoprostol, or with both mifepristone and misoprostol. 19 to 24 weeks of onward, you can use osmotic dilator plus either mifepristone or misoprostol, or with both mifi and misoprostol. Anti-D should be given from 12 weeks of the pregnancy, and that should be provided within 72 hours of abortion. In case of incomplete abortion, if there's no suspicion of infection and uterine size is less than 14 weeks, you have to give misoprostol 400 microgram sublingually, buccally or vaginally, or you can prescribe 600 microgram orally. In case of missed abortion, you have to prescribe first mifepristone, then 24 to 48 hours later, you can prescribe misoprostol. So you can either manage medically, or you can also do a surgical miscarriage, that is uterine evacuation with vacuum aspiration with antibiotic prophylaxis. But if it is more than 14 week size, in that case, 14 to 24 week size, you have to prescribe misoprostol 400 microgram sublingually, buccally, or vaginally. That will be every 3 hours. So you can see that before 14 weeks, you can give only a stat dose of misoprostol, but here you have to give every 3 hourly. In case of missed abortion, along with the misoprostol, before that you have to prescribe mifepristone 200 milligram orally, then 24 to 48 hours later, then you can add misoprostol. Or if you want to do by surgical management, you need to prescribe antibiotic, and then you can do vacuum aspiration for removal of the retained tissues. If the fetus is retained, in that case, before 14 weeks, you can do the vacuum aspiration, but 14 to 16 weeks, you need a forceps removal for the larger fetal part. But from 16 weeks, you have to use dilatation and evacuation for removal of the fetus from there. If you see any infections over there, in that case, uterus should be evacuated urgently with ultrasound guidance, and you need a broad spectrum antibiotic. That should be the combination of ampicillin 0.5 to 1 gram every 6 hourly, metronidazole 500 milligram 8 hourly, and gentamicin 120 milligram daily. And after the administration of the antibiotic in intravenous, then you can go for evacuation of the uterus. So this is all about the best practice of abortion care. If you have any queries, you can ask me on the comment box. I will be happy to answer all of your queries. And I'm requesting you to please subscribe my channel and press the bell button, and also press like button as well, and share with the other groups so that everyone can get help from these videos. Thank you. Thank you for watching.